My name is okay. Hello everyone. My name is Vivian and I am representing the presentation we had 2 weeks ago that was not completed. It's a case-based review featuring a woman with 3 week history of breathlessness and weight gain. These are the learning objectives, definition of AKI, recognition and clinical presentation of AKI, identifying the causes of AKI, management and appropriate escalation and referral. Okay, so we're going to be discussing this case review under these subtopics: introduction, the definition, epidemiology, causes, staging, management, and predictors of poor diagnosis. Okay, so case. This is the case. A 55-year-old woman referred by her GP to emergency department with a complaint of 3 week history of worsening shortness of breath, leg swelling, weight gain of about 10 kg, and she had no urinary symptoms, no chest pain, no gastrointestinal symptoms. At least no was written. And then in her past medical history, there's a positive family history of rheumatoid arthritis in her sisters, but she has no history of cardiovascular disease. The examination findings, these are the examination findings. She's alert and oriented. She was dyspneic with a respiratory rate of 24, which is high, and oxygen saturation of 93% on room air, as well as bibasal crackles. And her heart rate was 90 regular, BP 105/70 and then she had elevated JVP of about 6 centimeters, and temperature is normal. There was no abdominal findings, and she had bilateral pitting pedal edema up to the knees. With that presentation, these are differential diagnosis. It could be cardiac origin, either cardiac tamponade heart failure, or could be of pulmonary origin, pulmonary hypertension, or co-pulmonary, or acute PE. It could also be of renal origin, AKI, that we're going to be discussing later on, nephrotic syndrome, glomerulonephritis. It could also be of liver disease, liver origin, or endocrine hypothyroidism because of the weight gain. Then also this kind of presentation of fluid overload can be due to some medications like NSAID or steroids. So in her investigation, these were the investigation results. She did a blood test and and urinalysis. The blood test showed full blood count of about 11 point, hemoglobin of about 11.4. Her white cell count was elevated 8.5, and her platelets 220, and then she had hyponatremia 131. Her potassium was elevated 6.4, and she had metabolic acidosis with bicarbonate of -18 and a pH of 7.25. These other tests there are the C-reactive protein. Sorry, the C-reactive protein. I didn't write it here, but C-reactive protein in her results was 220. These other tests are the ones that ordinarily would be done: autoimmune screen, urinalysis. Now, with the presentation and these results, her most likely diagnosis is acute kidney injury. Reason for this diagnosis is that she had a rapid fluid accumulation which occurred under within the space of 3 weeks, and that she had systemic features, her elevated JVP and the bibasal crackles. Oh, I forgot to include the chest X-ray findings. She had okay, there was no chest X-ray finding. So her initial management. So now this we're suspecting acute kidney injury, and this will be the management of acute kidney injury, usually in high density unit. HGU, we'll use the ABCD approach. She's dyspneic, so we'll give her oxygen, and she has bibasal crackles with the so we'll give her I would give her IV furosemide diuretics to reduce the bibasal crackles. It's usually about 40 to 80 milligram, and we've taken her blood samples already. Then we want to correct the electrolytes. That was She has hyperkalemia. So we'll be correcting hyperkalemia with calcium gluconate, and then insulin and glucose infusion. Sometimes they also give some potassium resin like sodium zirconium for the correction of potassium. The metabolic acidosis is usually not corrected because when you correct the AKI, the acidosis corrects. But in the case where it's not corrected, then bicarbonate infusion is given. Then after that, we that's the management of the acute symptoms. Then we'll now treat the underlying causes. So we're going to be oh okay. Okay, so this was the chest X-ray findings in the woman: bilateral pleural effusion and congested lung fields. Other things I would want to do because of the differential diagnosis might be ECG, because we're thinking a heart symptom. But for this woman, this was what was given. And this will be the management in HDU. Usually, they are managed first in HDU. So there will be a daily urea and electrolyte tests, strict fluid input and output monitoring. We should usually hourly documentation of the input of the fluid intake, and you insert catheter to measure the fluid output. Also, we'll monitor their new score, that's daily continuous monitoring of the vital signs. The urgent renal ultrasound scan will help us determine one of the causes. If it's post-renal, it's usually due to urinary tract obstruction. So that will be seen with the renal ultrasound scan. If the potassium is greater than 6.5, usually ECG is done, but it's advised that if potassium level is this high, you can start treatment before you get the ECG results showing the hyperkalemia. And then for their management, you need to refer them to the nephrology unit. For the discussion, the definitive diagnosis in this woman's case is acute kidney injury, and the reason for the diagnosis in from her presentation is, in addition to um, her symptoms, the test showed raised creatinine of greater than 26.5 within 48 hours, and her creatinine compared to the baseline, her last creatinine was 80. So compared to the baseline, it was elevated for over 3 times more than the baseline. And she had pulmonary edema shown by the bibasal crackles and the chest X-ray findings. She also had hyponatremia, hyperkalemia, and metabolic acidosis. So here's the definition of acute kidney injury: is a clinical syndrome characterized by the rapid reduction in renal excretory function and glomerular filtration rate over hours to weeks, leading to impaired control of extracellular volume, electrolytes, and acid-base balance. Now, according to the kidney disease KDIGO, there's a definitive criteria for diagnosing AKI. Is that the serum creatinine is greater than or equal to 26.5 within 48 hours, or greater than or equal to 1.5 times the baseline, which is known or presumed to have occurred within the last 7 days, or an oliguria of less than 0.5 for 6 hours. Now, in this case review, this woman had elevated creatinine, and so she met the diagnostic criteria. The epidemiology: about 5% of acute hospital AKI contributes to about 5% of acute hospital admissions and about 30% of intensive treatment unit admissions, and has a 50% mortality rate. So, but this for acute kidney injury, we can check the severity of acute kidney injury based on the level of serum creatinine or the urine output. According to the same system of classification, diagnostic, according to the same system that gave the diagnostic criteria KDIGO, you could use that to stage the severity of AKI. So for stage one, is mild. The serum creatinine is either 1.5 to 1.9 times the baseline, or she has a urine output of greater than or equal to zero point 0.3 milligram per dl. Sorry, less than 0.5 mil per kg per hour for 6 to 12 hours. Stage 2, there's an elevated serum creatinine of 2.0 to 2.9 times the baseline, or the urine output is less than 0.5 times, but this one greater than or equal to 12 hours. And then for the stage 3 is severe. The baseline, the creatinine is like greater than is about 3 times the baseline. In this woman, that was what it was. Her baseline was 80, and her serum creatinine was 20, and the serum creatinine level at the time of presentation was 220. Also, at this stage, you might want to initiate renal replacement therapy, but we'll talk about that later. So the causes of acute kidney injury, there are different. There are three major. Is categorized into three. The causes of acute kidney injury. It could be prerenal, it could be renal, or postrenal. Now, prerenal is usually due to the prerenal causes are usually due to hypoperfusion. So things like that's why we have things like hypovolemia, or hemorrhagia, or or hemorrhage, or hypertension, anything that reduces the perfusion of the vessels of the kidney. We have the renal vein thrombosis, increased intra-abdominal pressure, ureteric stones, anything that, sorry, I'm listening. So prerenal is hypoperfusion. Renal is due to intrinsic causes, like intrinsic process occurring within the kidney, and then postrenal is due to the obstruction of the urinary tract. So the prerenal could be caused by hypovolemia, hypotension, or shock, and then hemorrhage. Then the the renal causes could be intrinsic factors like glomerulonephritis or interstitial nephritis. Then the postrenal causes is now the obstructive causes, which could be renal vein thrombosis, intertubular causes like when there's uric acid crystals, then ureteric stones, and then things like BPH that causes obstruction in the urinary tract. Okay, there was a confusion in my slides. Okay, then the principles of management. They are usually managed in the HGU, and the initial management would be oxygen therapy, the fluid restriction, and then the strict fluid input and output monitoring. Like I said before, to monitor the fluid, you would need to do we will need to insert the catheter to measure the urinary output, and as well hourly documentation of of her fluid intake. Because she had obvious features of fluid overload, we might consider giving her IV diuretics. Some school of thought do not want to give IV diuretics, but for a woman with the clinical presentations like this, we would want to give her IV diuretics of 40 to 80 milligram, and if she doesn't respond well, we double the dose. Then there are things that could cause it, like we said. She has a family history of rheumatoid arthritis, which means she may likely if she has rheumatoid arthritis, she may likely be on NSAIDs, which also causes AKI. So we might want to stop the offending medication, that's the NSAIDs, and then we would refer her to nephrology. Oh, we'll also do a daily monitoring of urea and electrolytes. Now, this lady, she was stage 3 because of the level of serum creatinine, and she might need renal replacement therapy. Now, there are specific indications for renal replacement therapy, and this includes refractory fluid overload, a fluid overload that's not responding to diuretics use, and then refractory hyperkalemia not responding to medications, and also severe metabolic acidosis with a pH of less than 7.1, and presence of uremic complications like encephalopathy, and a urea of greater than 45 millimoles per liter. So for AKI, there are things that could be predictors of poor outcome, and this includes advanced age, delayed presentation, severe fluid overload, oliguria or anuria, then sepsis, multi-organ failure, and then if she has the need for dialysis. Usually, if she has the need for dialysis, she either undergoes hemodialysis or hemofiltration, continuous venous hemofiltration. All right, so that brings us to the end of the presentation. These are my references. Thank you, everyone.
Well done. I think we'll leave a few minutes for questions. Okay, thank you, Vivian. In the absence of any questions, we'll close the presentation and the program as well. Thanks to everyone for engaging.
Thank you.